I'm Dr. Mike Milligan. I'm here with Dr. Doug Thompson of Bloomfield Hills, Michigan, one of the earliest general dentists involved with salivary testing for bacteria and the oral systemic effects of that. Doug, thanks so much for being with us.
Thanks, Mike. Thanks for the invite. I appreciate it.
Just gave a talk at our meeting here of dentists, a few hundred dentists, and answered 30 minutes of questions afterwards. It was a wonderful talk.
Thank you.
Tell us about the importance of testing for the actual bacteria in your mouth, and then the ramifications of what you find for the systemic concerns.
You know, Mike, I didn't realize what the testing might do for my practice when I started to do it, but when I first got introduced to testing, I started to have ineffective post-test results. In other words, I didn't get the test results that I thought I was going to get.
Okay.
And what the testing did was it elucidated the fact that my disinfection protocol was weak.
Okay.
And that the old traditional school thinking needed to be changed a little bit. So I looked at all the old total mouth disinfection literature and started to really refine our protocol.
Okay.
And the test was significant to help us understand what to do to treat the patient.
Sure.
We don't use the test to determine whether they have the disease.
Right.
We determine that through a periodontal chart, and we see active bleeding, and we see signs of earlier bone breakdown. But we take the test to help us learn how to treat the patient, what type of antibiotic we would use if we were going to use it, what maybe how aggressive the pathogen load is there. And as you know, with the most recent work of Dr. Bale and Dr. Doneen,
Right.
we have in the cardiovascular world some reason to be concerned about which pathogens might be present in someone's mouth.
A lot of reason to be concerned, you bet.
Yeah, so to give that merit, I thought that we really need to have this objective piece of data that we could use to help us formulate treatment, determine how aggressive or what kind of things we're going to do during treatment,
Right.
and to help us evaluate how effective our treatment was.
Right.
So I think if you're going to use the testing modality, you need to pre-test when the disease is discovered as active, stabilize the disease process, set some real strict criteria for what disease stabilization is, and then retest. And when you do that, and you do it over and over and over again, you'll see consistencies in the test that shows that you've either suppressed, eradicated, or altered the combination of bacteria in such a way that that patient's response is now healthy.
Clinically, a lot of times you can't tell that there are bad bacteria in there. You really need to do the test. And you're talking about bacterial testing such as the oral DNA or the Hain diagnostics.
Yeah, I mean, that's all we have right now. I mean, I think there are some tests available through some dental schools or through some research facilities, but those are very consumer friendly, they're easy, they're inexpensive, and so they're available to us.
Yeah.
Offices and dentists really need to think about how do they want to control periodontal disease in their practice.
Yeah.
In other words, what is it? When do I want to identify it? And then what am I going to do to treat it? And then how am I going to teach my patient about it? Because it's a very complex disease. And oftentimes we have a hard time thinking about complex diseases and coming up with protocols for that. So one of the things that, to try to simplify the process, I think you have to develop a periodontal policy.
Okay.
An office-wide policy about how we're going to handle this. And one of the first things you have to do is there has to be a leader. Somebody has to lead that policy, and that leader needs to establish and work with the team to establish when are we going to make the call that there's too much oral inflammation. When is disease?
Right.
And so the only way I've found effectively to be able to do that is through periodontal charting.
Sure.
And without effective periodontal charting, otherwise known as probing, but periodontal charting or gum mapping, we call it for our patients. Without that, it's the backbone. You're really dead in the water. It's the backbone of the.
How often do you do that?
All new patients get periodontal charting,
Okay.
but it depends on the classification of disease they have. If it's a patient that's perfectly healthy, no clinical attachment loss, no inflammation, they're going to get charted once a year.
Okay.
But the patients that have a periodontal need, they're going to get pericharted at every appointment. Our maintenance patients.
What are you talking about here?
Well, it depends. It depends on what you want as your, however much inflammation you're comfortable with.
Right.
And I think that if you go back from the old tooth loss days, we were thinking about, well, all we have to do is prevent the disease from spreading so we don't lose teeth.
Right.
I mean, there's a lot of disease present before that happens.
Right.
So at some point in that continuum, you should have the courage to say, hey, this is not normal.
Well,
and so for us,
early on in that.
yeah, and so for us, we established some disease criteria. Yeah. We had to arbitrarily pick a number of bleeding points that we were comfortable with, and we also helped calibrate the periodontal therapists on how much bleeding or what kind of bleeding is significant. Yeah, it can be looked up easily if you Google the papilla bleeding index.
Okay.
If you Google papilla bleeding index, you'll see a picture. You'll see 4 pictures, and one picture has point bleeding. One picture has line bleeding, where the line between the freegiginal margin and the tooth fills up with blood. Mm-hmm. Another picture shows triangular bleeding, where the whole triangle fills up with blood. Right. And then the 4th picture is droplet bleeding. I mean, the blood is running down the alveolus. Wow. That's heavy inflammation. I think that point bleeding might be, patients will have point bleeding to probing. I don't really know how much inflammation's there, but if they have line bleeding, if that line fills up, I can pretty comfortably say, unless my therapist was too aggressive, that they have inflammation. Right. And so we picked a number. In our office, we used 4 points of inflammation, and we use that as a springboard to start to talk to our patients about what might not be healthy, and what the ramifications of that might be. Mm-hmm. And you can use things, nice books out like the Inflammation Syndrome, or Dr. Bale and Dr. Doneen's work on the Beat the Heart Attack Gene. Out of that book, you could create a little excerpt, a little 1-page, why it's significant to control oral inflammation to help prevent heart disease. Right. You can really go into a lot of areas where there's good research. The ability for inflammation to alter or make it difficult for someone to control diabetes. Mm-hmm. There's a lot of different avenues, and you can pick what you're comfortable with, and you can talk to your patient about that. And your patients will not be comfortable with the fact that they know they have bleeding, and bleeding can alter some of these or affect some of these other diseases. Right. And they'll often ask you, Doc, what do we have to do to make that stop? Good. And then you can decide if you want to offer the patient more home care remedies, or maybe they're not doing hardly any microbial control on the teeth right now. Mm-hmm. Maybe they're not cleaning in between the teeth or the tops of the teeth very well. Right. So maybe it's a power brush and a water flosser, or maybe even it's a power brush and a floss, or a wishbone flosser. Mm-hmm. Some tools that you can put in the patient's hand to make them be more effective. And many patients would love to have an opportunity, maybe another chance at eliminating some of that bleeding, especially if it's just a little over our threshold, like maybe 5 to 10 bleeding sites. They might say, well, Doc, I know I haven't been really cleaning in between my teeth. I haven't been flossing, or I've been traveling a lot. Yeah. We hear that a lot.
Try to clean up themselves for a while.
Yeah, and so you say, it's not going to be a big deal. I tell them, if you have a real tenacious periodontal disease, you can't brush it away. Right. So if you want to try to do a little bit of work at home, go for it. And but here's what we can't do. We can't leave the recall frequency the same. We need to evaluate that patient a little bit more frequently than what we had done. Right. So we say to the patient, look, we'd love to have you be better, but I need to reevaluate a little sooner than 3 months or 4 months. So let's look at you in 8 weeks. Mm-hmm. Work your heart out. Go for it. We'll both celebrate if you come in and you're looking better. And I can tell you the patients with tenacious bacteria, they won't be better. Right. And those are the patients then that you would recommend that you would use the diagnostic test to help. The salivary diagnostic test. Okay. Yeah, and the one I like is from oral DNA, but to help you determine how you're going to treat that patient. And at that point, you have an established disease diagnosis, you have some objective data, which helps you determine what's driving that bleeding, and now you have to, as a doctor, formulate a plan, a disinfection protocol plan for how you're going to stabilize that infection.
What are some of the things you're using here?
Yeah, we like to mechanically debride the teeth, and it wouldn't matter to me if you used a piezo scaler, a Cavitron, a laser, some disinfectant, some mechanical debridement. Okay. Then I think it would be nice to irrigate the wound. So irrigating the wound would be, you could use a bleach-based rinse, something like Carefree treatment rinse. Okay. You could use iodine. Some people prefer to use chlorhexidine. It's not my first choice, but that's been used.
Discoloration.
Yeah, yeah, and for sure we never want to mix any kind of bleach-based product and chlorhexidine in the same mouth. That would be there's a chemical reaction that doesn't that it's not healthy.
Okay.
So it's either one or the other. Anything that you want to do in the crevice to help reduce the bacterial load, then you have to think about how you're going to remove the bacteria on the cheeks, the tongue, the roof of the mouth, other areas. And again, there's several good commercial rinses out there, commercial antibacterial rinses out there. Things like ProFresh, stabilized chlorine dioxide, carrier-free treatment rinse. There's different rinses that could be used for that. We happen to like the product ProFresh. It's a chlorine dioxide rinse. And we would have the patient use that. We typically use ProFresh once the patients have become stable. We use, during the healing phase, after we've irrigated the wound, during the healing phase after scaling and root planing, we really like to use the carry-free CTX4 treatment rinse. It's a 0.2% bleach-based solution. It kind of keeps on killing, and it strips biofilm. Very effective for oral bacteria management. We'd have to go on the record as saying that's an off-label use for that product. It's really designed for caries biofilm management. But my feeling was when I saw the product come out that caries biofilm and periodontal biofilm are really similar. And so you could strip the periodontal biofilm as well. So we have mechanical debridement, gingival or sulcular lavage. We have oral disinfection through rinsing. And then we need to do something with the blood because we haven't taken care of or even considered all the bacteria that either burrow in the tissue out of our reach or travel through the blood. So we really use the oral DNA test or the bacteria test to help us select the most targeted antibiotic for that bacteria profile.
And they help you with that on the report?
They do. They do. And so there's that piece that you have to consider, and it's the aggressiveness of the infection. You have to decide as the practitioner when you want to use the antibiotic and pull the antibiotic trump card. We have good science that shows that using antibiotics increases the effectiveness of our scaling and root planing. So very few patients, if I really want to disinfect and do a great job, most patients are getting supported with an antibiotic. The other thing I think that the patients, speaking of patient support, is that antibiotics can cause antibiotic-associated diarrhea. You know that if we use clindamycin, there's the discussion about pseudomembranous colitis and that issue. So all of the patients that get an antibiotic recommended are offered a probiotic. And I typically like a good pharmaceutical grade probiotic that has Saccharomyces boulardii in it, which is a yeast that helps the C. diff. It helps prevent the C. diff issue, and it helps prevent antibiotic-associated diarrhea. And there's a little bit of research on that.
So they're using this at the same time as the antibiotic, and it's
That's
typically
correct.
You're looking at a week or two.
Yeah, 10 days. Except that I think it's good to stay on the probiotic. There can be a lingering gut flora imbalance from the antibiotic, so I think they should be on the probiotics for at least a month. And again, a good nutraceutical grade. Several companies out there like Metagenics or Designs for Health can provide that product. So we
nutraceutical grade
or a probiotic,
Gotcha.
and just not something that you're going to go down and grab off the drugstore shelf. And because of that yeast component, special yeast component, and then in addition to that, they have to. That's kind of our in-office protocol. So the day of the disinfection, you've done a great job around the teeth. You've attacked it chemically. You've attacked it in the bloodstream. You've given them a rinse to rinse the rest of the mouth, and it's a very effective baseline. That's my baseline disinfectant protocol. We build on it from there. If we see patients that don't respond, if they have a hard time getting stable, then we only build on it from there. And then we look at other. I mean, Mike offer a 2-day course in this, so I can.
I know you do.
I could go on forever.
But I'm giving you the 2-day course, crunched down.
But then we have to. But
you take the course.
Yeah, but then we have to start looking at other things that's going on in the patient's life, like maybe the spouse is contributing bacteria. Maybe there's some other reasons why it's hard for them to control that microbial load. So, but putting the protocol all together, it's a very effective microbial load control modality. And that's really what you're trying to do. And I think we've proven test after test that when the oral cavity expresses disease, there's typically an oral imbalance, a microbial imbalance, and when you bring that microbial population back into balance with normal commensal healthy bacteria, you get beautiful disease stabilization, and you get a healthy patient.
Okay, so then you retest once you feel like the mouth is healthy, the bacterial test.
And zero bleeding.
Salivary test, and zero bleeding, okay. And then what do you do for maintenance from then on?
Maintenance, we switch them now from the more powerful bleach-based rinse for the oral cavity to ProFresh. That would be that's my choice. That's the chlorine dioxide-based rinse. And then we would like to have them irrigating between the teeth. Depending on the periodontal diagnosis, I don't think string is the best thing to clean the teeth. I mean floss, right? I'm being kind of funny about that, but because teeth roots have concavities and have abnormal shapes, that string just hits the high spot. So some kind of power washing, if you will. So whether it's a hydrofloss or a water pick, whatever that is, we can do two things. We can apply a little bit of Venturi effect or forceful effect to help the pathogens in the pocket, to eliminate some of the pathogens in the pocket. We can also deliver some medicaments through the water pick. We would use for the people who really want an all-natural health alternative, grapefruit seed extract is an ammonium quaternary compound, all naturally occurring, and so you can Amazon.com, you can buy a bottle of grapefruit seed extract, and they can squeeze 20 drops in the water pick and turn it into a little medicinal. Okay. So it's a nice thing. So it's a very effective. Than a power brush, we find patients do better with a mechanical brush than they do with a handheld brush.
We find that too.
Some patients love their handheld brushes and they do a great job with it. But if they're providing effective plaque management, I don't really care what they use.
Sure.
And so that's the goal. So the other thing is a tighter recare until you see some period of stability. So I would prefer a 2-month or a little tighter recare, because I think 3-month they miss an appointment, something changes in the schedule, it gets to be 4. The bacteria population continue to grow. Right. I'm not intimately familiar with the science and the research, but I think the 3-month time frame was established because of maybe the life cycle of the population or regrowth of the bacteria. Okay. And so if we can get in there and give them a little professional assistance and some reassurance and some feedback on a 2-month basis, then we can graduate them out maybe to 3 or 4 months after they kind of earn the right to be there.
Okay, and you're looking at a few recalls, stability at the 2-month before you're going to graduate them.
Yeah, we do that a lot. And what we found through our clinical trial, if you will, or just from clinical experience, is that the average patient takes a little longer to get stable than the traditional 8 weeks that we think that we used to use. Right. I mean, we would think, 8 weeks they're going to be better. Some patients just take longer than that. And so if you let them out of your care, and you push them back out on a 3-month, you might be disappointed. Right. And what we really do, and what we really want to do, and this is what I love about Dr. Bale's work, is he kind of guarantees anybody under his care is not going to have a heart attack or a stroke. I think that's a pretty awesome guarantee from a healthcare provider.
I'm a patient of theirs.
Yeah, as am I.
Yeah,
but one of the things that I like to do is to mention to patients, if they make the financial investment in my office to have the disease controlled, I really want to see them get to stability, and I really want to help them get to stability. So we sometimes have to do maybe another little mini disinfection appointment at no charge, but we do some things. They've made a commitment to you, and now you need to help them and figure out how to get them stable. And sometimes it's difficult. What the bacterial testing, again, did for me in the beginning was it really confirmed that my old traditional disinfection protocol of just using a little chlorhexidine, maybe the odd little Arrestin here or there or something like that. And speaking of which, in the disinfection protocol, we usually use Arrestin in all pockets greater to or equal to 5. So if you have 5mm pockets, I think right now it's the best timed release antibiotic to stuff in the crevice. I mean, I think something else will come out better in the future maybe, but right now I'm trying to use the best medicines out of everything that we have, trying to use the best medicines that we have to do that.
So what about worse than this? you have a periodontist you work with?
I do. I think that if you have pockets that are relatively stable that exceed 5 millimeters or 4 millimeters, I think it's a great idea to get your periodontist on board and figure out how to do some pocket elimination surgery, make it easier for the patient to succeed. Right? That's really what you're trying to do. And you do that by kind of reshaping the gingival architecture, and you allow the patient an opportunity to maybe have better access for cleaning and a shallower pocket. I mean, we know that these bacteria that grow in deep pockets grow there for a reason. So if we can make the pocket shallower, it's harder for those bacteria that love to live in the absence of oxygen. It makes it harder for them to survive. So that's a good thing. And the periodontist, the other thing that happens is they really appreciate you disinfecting your patients prior to implant placement. So if you're not a practitioner that's placing implants in your office right now, if you're sending them to an oral surgeon or a periodontist, they love to have the patients really, really healthy when they get there because there's less surgical complication, less failure, and so it's a better that's a better thing for them. One other thing is that if you do have to ultimately employ gum surgery, after your disinfection modality and a really comprehensive periodontal management treatment protocol, the surgery is going to be less. They're going to heal faster. It's going to be less extensive for them, and sometimes they need that, but it can be better for them.
Great. Any last things you'd like to? Thank you so much for all of this great information. Doug's is as good as I've seen. He's one of the earliest adopters of this really upcoming, the way it's going to be treated in the future, and he's research based. He's established his protocol. And so we really appreciate this. Any last things you'd like to tell us before we close here?
Well, I think one of the other unexpected realizations that happened through this whole thing was that I didn't realize how happy my team would be about the whole, just the periodontal maintenance appointments. They're almost fun now. Right? You get the chance to celebrate the success with the patients, and it's not that old, beating patients up and feeling guilty. We're not doing a good enough job. You're not brushing well enough, and I feel much more like we're managing disease like maybe a medical provider might, and we're providing less repair. I would also say that when you're controlling the periodontal pathogens at that level, long term, there's less incidence of other related disease like caries, another bacteria that loves an acid environment, a biofilm disease. And so these periodontal maintenance patients have more exposed root surfaces that are still hard and firm and not carious. And so I think that we're cutting down on, for sure we're lowering the risk of other systemic implications that can come from the bacteria, but we're also preventing other related dental diseases, which is really nice. One of the things that some people have said to me is, well, we make our money repairing teeth. I really would like for us as a profession to start to get paid for how we think through things, and employing sophisticated disease prevention strategies and less repair strategy.
Absolutely.
And Mike, one of the persons who's been influential in my dental development, my professional development as a dentist, is Dr. John Coys. And Dr. Coys said really early in one of his treatment planning courses, wouldn't it be cool if we could predict who was going to get the disease before they got it? And one of the things that controlling periodontal disease, learning how to manage occlusal disease, learning how to manage biocorrosion and abfraction lesions, and how to maybe have a play in controlling oral pH, how to identify sleep apnea, how to have a sophisticated system or a little bit better than your eyes to look for oral cancer, and then how to make the patient cosmetically pleasing so they can have good personality development, social confidence. This is the backbone of the wellness practice. Absolutely. And John Coys has been talking about risk-based care and how to move our patients through better education. An informed patient's a better patient. And we spend more time educating and thinking through things than we do drilling, and that's a lot of fun.
Absolutely. Where do we get more information from you?
Well, you can always email me personally at Dr. Doug at I, as in I, Oral Med, ORALMED.com. Impact Dental Solutions is kind of my...
Impact Dental Solutions.
ImpactDentalSolutions.com. Dr. Doug at IOralMed.com. The name of my practice is Integrative Oral Medicine, so if you put in Integrative Oral Medicine, and we'll find it. And I'm really trying to help people learn how to teach their patients and their teams how to practice personalized periodontal medicine. We didn't even talk, Mike, much about the collaboration with physicians in the community, but it's a wonderful avenue to reach out to physicians in a very polite way and ask them for their help in managing the patients. And when they see what you do, they'll know you're different, and you'll get some referrals.
And you'll be surprised how accepting they are of the information.
There's no question.
And they then do appreciate it and refer to you.
There's no question. And we're really blessed to have Brad Bale and Dr. Amy Doneen going around the country teaching physicians, and they have such a strong dental component to their program that I recommend if this is for dental professionals, I recommend that everybody seek out that course so that they can learn the significance of the oral pathogens and what it means to vascular wellness. That's important.
Right. Dr. Thompson, thanks so much for being with us.
Thanks, Mike. I appreciate it.